Good day to one and all present here. This is Prithvi Ramamurthy, CRRA at KG Hospital, and this is Prashanthi Ravikumar, CRRA at KG Hospital.
Today we are going to present on the topic Evolving Clinical Management from Observational Study of 100 COVID patients for 10 days.
This study was done under the guidance of Dr. Mageshwaran sir, pulmonologist, and Dr. Ilangovan sir, chief nephrologist, and Professor A. Rajagopal sir, analytics and research.
Background of the study: cluster of pneumonia cases surfaced in Wuhan district of Hubei province of China in December 2019, the political, cultural and the economic hub of China. When the number kept swelling further, investigation by CT scan noting the cluster of respiratory illness on the possibility of viral pneumonia, it was found to be as same as SARS coronavirus that caused in 2002 but in a different mutation. There was an incubation time to note symptoms after infection, causing silent spread, first noted from now infamous Wuhan seafood market.
India is battling a second wave of COVID-19. As of May 4, 2021, more than 20.2 million cases of COVID-19 has been reported with a rolling average of 378,000 cases a day, together with more than 222,000 deaths. The source is from the Lancet. Tamil Nadu confirmed over 2.4 million cases of COVID-19 as of June 20, 2021, with 31,000 fatalities and 2.3 million recovery. The source is from the Statista. During this COVID-19 pandemic, KG Hospital played a crucial role with a team of doctors and healthcare workers, and they extended their hospitalization in their wing at Saravanambatti by providing 195 beds for COVID-19 patients.
Our aim is to decide the progress of the disease with the following parameters, that is, to discharge without oxygen, to discharge with oxygen intervention, shifted for emergency with oxygen, monitoring with oxygen, monitoring without oxygen, and death. The objective of our study includes the probability of patient event as above were found based on the laboratory and patient parameters. Total requirement for oxygen for 7 days since admission was predicted. The influencing critical parameters for daily monitoring were determined for its threshold levels. These are the following questions we will be answering.
The study includes total of 100 patients, and the 50 patients were totally focused on non-diabetic patients, and rest of the 50 patients were focused on diabetic patients. So the whole study will be answered in a way by answering these following 10 questions. The questions include: what are the patient presenting pre-existing comorbid conditions with gender as dichotomy variable? The second one includes: is there any relationship between 12 feature variables? The variables are serum parameters, respiratory parameters, demographics and symptoms. The third question is: which are the significant factors as biomarkers that explains the interdependence for 11 continuous feature variables? And the fourth one is: which are the predicting determinants of biomarkers that should be monitored? Clinical intervention management in 10 days since admission to minimum oxygen demands in liters for first 7 days. And the fifth question is: what is the threshold level of laboratory serum biomarkers to minimize the oxygen demand?
Can you tell under what circumstances a patient need maximum oxygen requirements, patient for first 7 days as well as minimum oxygen requirements? The seventh question is: what is patient outcome in respect of discharge? The eighth one is: what is the odds ratio of discharge comparing to shifting to emergency with oxygen at different levels of biomarkers? The ninth one: what are the therapeutic drugs and the biomarkers level that can prevent mortality in emergency ICU? 10th, what is the planned strategy for wave 3 to present context of Delta plus and threat of mucormycosis?
Coming to discussing the first question: what are the patient presenting pre-existing comorbid condition with gender as dichotomy variable?
32% of the COVID patients presented were male non-comorbid, while followed by 14% female. 8 were male comorbid, followed by 4% female. Remaining 20 categorical combinations contribute to the 40%.
Is there any relationship between these 12 serum parameters, which include the serum parameters, respiratory parameters, and demographics and symptoms?
Serum parameters include ferritin, C-reactive proteins, D-dimers, platelets, sodium, potassium, and RBC. Respiratory parameters include mode O2, standardized CT score out of 40. Demographic and symptoms include age, taste, and smell. Correlation analysis established interdependence of these variables and therefore reduced for its maximum contribution total structural variation. 7 out of 55 pairs were interdependent by correlation.
In this study, which are the important factors as biomarkers that explains the interdependence for 11 continuous feature variables?
Ferritin, D-dimer, platelet, mode O2, and potassium contributes to higher loading to total variations.
Which are the predicting determinants of biomarkers that should be monitored for clinical interventional management in 10 days, since to minimize the oxygen demand in liters for the first 7 days?
Ferritin in nanogram per milliliter with p-value less than 0.010, taste and smell with p-value less than 0.010, explains significantly on the prediction of O2 consumption for the next 7 days. All other p-values are more than 0.20. Female with comorbid were significant with p-value less than 0.03. These become the predicting determinants for total oxygen consumption for the next 7 days after admission.
What is the threshold level of laboratory serum biomarkers to minimize the oxygen demand?
Ferritin below 300, potassium from 4 to 5.5, HbA1c between 6 and 7 do not require oxygen. The impact of COVID-19 on blood glucose, a systemic review and meta-analysis, Juan Duani, 5 October 2020 was reviewed to support our findings.
Can you tell under what circumstances a patient need a maximum oxygen requirement for first 7 days as well as the minimum oxygen requirement?
While the male non-comorbid takes 6 liters, female non-comorbid takes 8 liters, male comorbid takes 9 liters and female comorbid takes 25 liters. It increases by half liter per every 100 points increase in ferritin. Further analytics was carried out for the eventuality of patients according to the comorbid conditions by my colleague Dr. Prithvi Ramamurthy.
Initially, the first 5 questions answered by Prashanthi Ravikumar was purely based on non-diabetic patients. It doesn't mean that the study doesn't include the non-diabetic patients. Only 5 diabetic patients were included in our study. Unlike in my study, there were nearly 45 diabetic patients out of 50. So the following 4 questions will be answered based on those findings which were obtained from my study.
What is the patient outcome in respect of discharge?
For that, remaining 3/4 of the patient were discharged without O2 and remaining 24%, the 20% shifted to emergency with O2 to the ICU and the remaining 2% of the patient either discharged with O2 or that ended up in the mortality.
What is the odds ratio of discharge compared to shifting to emergency with oxygen at different level of biomarkers?
The important finding in this study was, in case of mortality, the potassium causes manifold, that is 479 times when shifted to emergency. And the study was supported by assessment of hypokalemia and clinical characteristics in patients with coronavirus in Wenzhou, China. And this study was done by Dong et al. On June 11, 2020. So this study was supporting our findings.
What are the therapeutic drugs and biomarker levels that can prevent mortality, emergency ICU?
As all of you are aware, most of the antivirals, steroids, vitamin C and antibiotics were given during the inpatient treatment on day-to-day basis symptomatically. It was noticed that usual popular diagnostic parameters which include oxygen saturation level, CT score level, RT-PCR cycle were indicative, but monitoring were the one we have identified. Hypokalemia and hyperferritinemia according to the comorbid conditions. The validation of hypokalemia and hyperferritinemia is being carried out for the ICU patients. The combinatorial trial effect of treatment associated with the biomarkers as clinical trial between the non-diabetic patients and diabetic patients will be planned for the future research.
What is the planned strategy for wave 3 to present context of Delta plus and to threat of mucormycosis?
Research need to be carried out in COVID-19 patients for better prevention and management of opportunistic infections like mucormycosis in order to reduce its incidence and morbidity. Prophylactic treatment protocols need to be established along with the rational use of the corticosteroids. The source is from the PubMed. And India has been undertaking the world's largest vaccination drive. Here it is important to understand that vaccines are just a preventive tool. It is not the treatment to be administered to reduce the level of the caseload in the middle of the wave 3rd. And more vaccination and COVID appropriating behavior could play an important role in mitigating the 3rd wave. However, hypokalemia and hyperferritinemia with the interventional medicine will be followed for the patients with comorbid conditions. Thank you.